We are live now, sir. Over to Dr. Sika.
Good evening, everyone. I am Dr. Shikha Verma, Medical Advisor for Lupin Oncology. On behalf of Lupin, I welcome you all for today's ISP. The program director for the session is Dr. M.P. Agarwal. Sir is one of the most senior and well-renowned hematologists in the country. It's in fact a great privilege to have you here, sir. Although Sir himself needs no introduction, it's my pleasure to speak a few words about Sir. So is a professor and head Department of Hematology at Bombay Hospital Institute of Medical Sciences, Mumbai. He's also a consultant hematologist at number of hospitals in Mumbai, including Leelavati Hospital and Breach Candy Hospital. He holds a number of professional and academic achievements apart from receiving many awards. He's an eminent international speaker and conducted multiple workshops at various prestigious institutions. Sir is a president Mumbai Hematology Group and is past president Indian Society of Hematology and Transfusion Medicine. He has authored multiple books and was an editor of Indian Journal of Hematology and other newsletters. He has multiple peer-reviewed publications, both national and international. We welcome you, sir. Please take over the session. Thank you so much.
Thank you so much for that kind introduction. It's my pleasure to introduce our guest speaker this evening, Dr. George Cortes. Dr. George Cortes is Director, Georgia Cancer Center in Augusta. All of us know him more as the Director of Leukemia Services at MD Anderson Cancer Center, where he was there for 3 decades and just moved about a year back to Georgia. Dr. Cortes is a member of the Board of Directors of International CML Foundation and President of Latin American Leukemia Net. He led the development of all the TKIs, as a result of which eventually they got approved through the US FDA for the treatment of chronic myeloid leukemia. And all of those who have been in the field of CML for last 20 years have seen and heard Dr. George Cortes talking about TKIs all around the world in all the meetings. He's authored over 800 peer-reviewed medical publications in top-tier journals. He's authored several books and chapters in various books, including Cancer Medicine and Harrison's Principles of Internal Medicine. He was associate editor for Blood and served in the editorial board of JCO, Clinical Cancer Research, Leukemia, Lymphoma, and American Journal of Hematology. In MD Anderson, he was chair of the Executive Institutional Review Board and chair of the Executive Committee of the Medical Staff and Program Director of the Leukemia Fellowship Program. It is not easy to get Dr. Cortes to spare some time and address his colleagues in this country, and we are extremely fortunate and extremely obliged to him for sparing his morning and evening for us to address us on 2 very important subjects. He's going to speak to us on management of chronic myeloid leukemia, where are we heading, and then Dasatinib, its rational placement in the treatment of CML. So these are going to be back-to-back lectures, and then he's also with us for the panel discussion with Indian faculty. Over to Dr. Cortes.
Thank you very much, Dr. Agarwal, and thank you very much, all of you, for being here present tonight for you, this morning for me. It is my pleasure to share with you some of my thoughts and some of the data that we have. It is very unfortunate we cannot be together. Of course, we are all facing very difficult circumstances. So, but I think we're fortunate to have now this ability to meet this way. As Dr. Agarwal mentioned, we're going to be talking about 2 different topics, but of course very much related to each other. The first one, I'm just going to share my thoughts about where we are on the state of the art in CML in 2020. Let me see. I'm going to share my slides, my screen, and if somebody can confirm that you are seeing my titles.
Sir.
Yes,
we can see your slide.
Perfect, thank you. So we're going to start talking about the state of the art then in CML in 2020. Much has advanced in CML, as you know, but there are still a lot of important questions and things that we need to debate. However, it is very clear that patients that have good access to treatment and a good management through monitoring and attention to all their comorbidities, etc., they can have a near normal life expectancy. This is the experience we published from MD Anderson. As you can see, patients are really living as long as others, they're same age and same sex, etc., and they're not dying of CML for the most part. Now, unfortunately, this is not true everywhere. On the left here, you see progress in the life, the expectancy of patients diagnosed with CML through the different decades at MD Anderson. And it is clear that the natural history of the disease has changed. On the right, you see the epidemiologic data for the United States. And even though many times people think about the United States as, everybody has good access and everybody does well, you can see that the progress is not the same when you look at the general population. Many individuals do not have insurance, they do not have access to care, they do not have access to the drugs, or they don't get the adequate care even if they have the access to all these methodologies. So there's clearly a lot of progress to be made in this disease for everybody. Although we have the tools, I don't think we have been able to make it reach everybody. One important thing is that we know that when we give patients with CML treatment with tyrosine kinase inhibitors, they do very well and better with the second generation TKIs. This is a summary of the randomized trials of the 3 second generation drugs that have been approved for frontline therapy: Dasatinib, Nilotinib, and Bosutini, and the comparator, which was Imatinib, for the 3 of them. And if you focus on what I'm showing you here, the major molecular response rate in the early time points, you can see that the results are very similar. The solid bars here represent the second generation TKI, and you see they are almost overlapping. Now, interestingly enough, the arm is also very similar, except for the most recent trial, the Bella trial, where the Imatinib results are significantly better. You can see here there's a differential of about 10-15 percentage points. So we've gotten a higher response rate with Imatinib at the 12-month mark. Now, even then, the results with Bosutini were significantly better. But that may tell us that over time we've gotten better at managing patients, being able to recognize the important time points and all of that, perhaps explaining that improvement also on the Imatinib arm. I'm just going to go into a little bit more detail in one of these studies because it has the longest follow-up, and that's the ENESTnd. This was presented last year at ASH, and it has 10 years now of follow-up. If you remember, this study was started in around 2006, 2007, something like that. You all know the design of the study, a randomized 1:1:1 between Nilotinib and Imatinib, 2 different dose schedules of Nilotinib. Of course, we know now that the 300 twice a day became the standard. And here are some of the important findings. Very importantly, there is no difference in progression-free survival, and there is no difference in overall survival. And people ask, what is the point if you're not going to see a difference in overall survival? And I think we need to remember that with Imatinib, because of a very high rate of complete cytogenetic responses, which is the one response that is associated with improved survival, then you've already reached the normal life expectancy, nearly normal life expectancy in patients that are treated with Imatinib. So you're not going to do better than that. The survival already has reached essentially its maximum. Now, before I get to other benefits of Nilotinib, if you look at the bottom panel here on this slide, one of the concerns that we have now with the tyrosine kinase inhibitors, with most of them, is the occurrence of arterial occlusive events, or I'm showing you down here the cardiovascular events, and you can see that it's significantly higher with nilotinib and with imatinib, and it continues to increase it over time by 10 years. The incidence of these events is about fourfold higher with nilotinib at the 300 milligrams twice daily compared to the imatinib. So this is something that we need to keep in mind. Also, if you see the shape of those curves, there is really no plateau yet, at least not up until 10 years. We'll see what happens with continuation of follow-up of these patients. Now, there are other benefits of these drugs, of course, and survival is not, once you reach the normal life expectancy, you look for other benefits, and there are others. If you focus on the cumulative incidence of major molecular response, and perhaps more important nowadays, on the cumulative incidence of MR4.5, it is very clear that there is an advantage for nilotinib compared to imatinib. In the MR4.5, for example, we are at 60% with nilotinib compared to only 39% with imatinib. That 39% is very good, of course, but you can do better with nilotinib in this context. So we need to remember that second-generation TKIs, when you use them as initial therapy, they have many benefits. They do give you more responses. They do give you faster responses. We're going to touch about that a little bit later in the presentation. We do give you the deeper responses. We just saw the MR4.5. And not only that, but they also give you more sustained deep molecular responses. The incidence of deep molecular response sustained for at least 2 years in this ENESTnd, and the data has only been presented for 5 years. But it is about 40 to 45% with nilotinib compared to only about 25% with imatinib, so significantly better. And there are fewer transformations, but they will not prolong survival. I already explained why. They do not prolong event-free survival or progression-free survival, kind of the same reasons that I detailed for survival. And they do not improve safety. There are some adverse events that improve, but others do not, and particularly the arteriocclusive events, which is something of concern. Now, as good as these second-generation TKIs are, and we have in our minds perhaps the perception that patients, they all do very well, look at the incidence of treatment discontinuation according to what's been reported at time points. As you can see, by 2 years, already about 25 to 30% of patients with the second-generation TKI have discontinued therapy, and it's very similar for Dasatinib, Nilotinib, and Bosutini. A little bit higher with imatinib, but not that much higher. At 5 years, that reaches almost 40% with the second-generation TKIs. And at 10 years, almost 50% of patients have discontinued therapy. If you consider discontinuation of therapy, whatever the reason, as a failure, only half of our patients are going to be doing well. Others will have to change therapy for one reason or another. Now, my impression is that we are discontinuing therapy much more than we really need to discontinue therapy. But whatever the case, only half of our patients by 10 years we consider a success. That brings me to the new ELN recommendation. This is the 2013 version of the recommendations according to the European Leukemia Net, they have been updated, of course, in the 2020. But because most of the data that we have so far is using the older criteria, I'm going to focus on the failure using the 2013 recommendation. Perhaps the one big change that I'm going to highlight later is the criteria for the 3 months. So keep that in mind, that here in the 2013 is no cytogenetic response what constituted a failure. Well, when you look at what happens on patients who meet that criteria for failure, their survival goes down. And not only that, but the more TKIs that we use on a patient, their expected survival goes down significantly. So it is important to keep in mind that that really has a prognostic implication. It's just a matter of an increased PCR. But keep in mind, this is by using strictly the criteria for the European Leukemia Net. If you change the drug because the patient is not in complete molecular remission, that is not a failure. That is not even a warning. So that doesn't constitute one of these adverse features that you see reflected on this slide. For second line therapy, we do not have a direct comparison between the 3 second generation. But if you look at the comparative or at the summary data with the 3 main drugs, Dasatinib, Nilotinib, and Bosutini, and keep in mind, I'm showing you here only the 2-year data, but you see the data is very comparable. The reason I'm showing you the 2-year data is because if you recall, these studies, because they date in the early 2000s, they were mostly focused on cytogenetic responses, and a plateau of the cytogenetic responses occurred by 2 years. So if you look at that 2-year mark, you see that the rate of complete cytogenetic response is 40% across the board, very similar. But think a little about this. We think that we have excellent subsequent therapy for our patients. However, this is complete cytogenetic response on patients that have only received imatinib previously in terms of TKIs, and yet only 40% of patients, 45% at maximum, will achieve a complete cytogenetic response. So our treatment strategies are good, but they're not great. Of course, if you were to look at the major molecular response and deeper molecular responses, the results will look much worse. So there's certainly room for improvement in the second line therapy, even when we're talking about, again, only imatinib failure. We know that the different drugs have different abilities to inhibit the BCR-ABL in the presence of different mutations, and here you see some of the important ones. Of course, for T359, only ponatinib works, and then a few of the others. I want to highlight this one here, the E255V and K. This is a mutation that has a very poor prognosis, perhaps the worst after the T359, and because we have now ponatinib, it's perhaps even the worst of all of them. It has the highest IC50, for example, for ponatinib, since it works well for T359. And this is a study that we recently published on the significance of this particular mutation. This is only 48 patients, but if you look, for example, in the chronic phase, there were 14 patients, and 8 of them have transformed to accelerated phase and blast phase. 9 of them have died. Very, very few responses. And in accelerated phase and even in blast phase, the results are even worse. So this is a very bad mutation, very poor prognosis that really needs to be considered very seriously. We all know that if we select the TKI based on the presence of mutations, that is predictive of outcome. But it's not predictive of outcome across the board. It is predictive for response in the chronic phase and in the accelerated phase, not in the blast phase. And it is predictive of event-free survival in the chronic phase, but not in the accelerated phase. And why is that? Well, because remember, as the patients move to accelerated phase and even more to blast phase, they acquire additional molecular events starting to drive some of the disease. So even if you inhibit BCR-ABL by giving a TKI that properly inhibits that because of the mutation profile, etc., there are still other drivers of the disease that are going to make the prognosis look worse. And we're starting to learn little by little more the value of these additional mutations. So when do you look for mutations then? Well, this is an old study, but I think it's very informative because it shows us that when you look for mutations on patients that have only a suboptimal response, or a warning as we call it nowadays, the probability of finding mutations is very low. If you're looking for a mutation in a patient just because they have not achieved a major molecular response, hardly ever will you find a mutation, at least not by Sanger sequencing. On patients that have lost the response is when you, and that is loss of cytogenetic or hematologic response, that is when you're going to find the highest rate of mutations. But even then, it's only 30 to 50% of patients who will have a mutation. So most of our patients that meet criteria for failure will not have a detectable mutation. So what new options do we have coming on the pipeline? And these are some of the new TKIs that are under development. Asciminib, I'm going to spend a little bit more time on that one because I think this is the one that's closest to possibly being approved. And then we have Dasatinib. That is a second generation TKI that has been approved in South Korea and I believe in Singapore, but there's very few data outside of those areas. And then there's three drugs that are still early, just completing phase 1 data. PF114 that is very similar to ponatinib structurally, but it does not inhibit VEGF receptor. HQP1351, a drug that's particularly active against T359, and KO706, a drug that has no activity against T359, but has shown activity against the other mutations. So let's look at asciminib. Asciminib is an allosteric inhibitor that binds in a different area of BCR-ABL, not in the ATP binding pocket like all the other ones, but in this myristoyl binding site. This myristoyl residue has an auto-inhibitory activity against ABL. When it's bound to BCR, when you have BCR-ABL, that auto-inhibition is lost. And asciminib can restore that ability to inhibit. Because of the binding site, it is not affected by some of the most common mutations that we see with the usual TKIs. It is certainly active against T359. You see for nilotinib, for example, the IC50 for T359 is very high. You can never reach these concentrations, whereas asciminib works well against these mutations. But it is prone to development of mutations in different areas that do not affect nilotinib or the other classic TKI. The data has been recently published with the early phase 1 study of asciminib, and it's very active. This is a study for patients who have failed 2 or 3 tyrosine kinase inhibitors at least, and yet 70% of patients achieve a major cytogenetic response, and even by 12 months, 50% almost of patients have achieved a major molecular response. And you see here the data with T359, 60% of patients with major cytogenetic response, almost 30% with major molecular response. Now, keep in mind that for T359, you do need higher concentrations. The dose that's going to be recommended for T359 is likely to be higher. So we'll have to see what the results of the pivotal study are. They have not been disclosed. I don't know them, so I cannot tell you anything anyway. But the study has been completed on the third line, randomized to Bosutini. So we should be hearing that data pretty soon. Briefly, these are the other TKIs. This is PF114. Remember, I told you this drug is structurally similar to ponatinib. In this study, where patients had received all 2 TKIs or more, or had T359, you see a major cytogenetic response rate of 50% and a major molecular response rate of 36%. There is no cardiac toxicity. There was skin toxicity similar to ponatinib in that regard. This is HQP1351. I told you this drug is very active against T359, and actually most of the patients in this study, 2/3, have T359. This is a group. This is a study where the patients are not as heavily treated as with the other studies, but it has activity. But if you look at these graphics here, you see how much more selective it is against T359. The red bars represent the response in patients with T359. The green bars represent the response in patients without T359. And you can see there is a big gap in the response rate, and the deeper you look at the responses, the bigger the gap. But certainly it looks like active against T359, much more modest against the other mutations. In accelerated phase, actually, there are no responses in the non-T359 mutated patients, although, of course, this is a very small cohort. This is KO706. This is actually a drug that's being developed in India by Sun Pharma. The phase 1 has also been completed. Remember, this one does not have activity against T359. But you see the patients that received a dose of 174 milligrams or higher. This is a phase 1, so the lower doses are not predicted to be effective. But once we got to these doses, you see a very high rate of responses, whether achieving or maintaining. Some patients already had that response when they went into the study. And even 50% of patients have achieved a major molecular response. So a very active drug in this regard. Now let me move to a different topic, which is the issue of these deep molecular responses going back to the frontline therapy. I showed you already the data with the ENESTnd. I'm going back here to the 5-year data to show side-to-side Nilotinib and Dasatinib. And you can see the Imatinib data is very similar, 31.3%. The second generation looks a little bit higher with Nilotinib at 54% at the 300 twice a day, compared to 42% with Dasatinib. Different studies, so you cannot draw too many conclusions about this kind of comparisons, but it does stand out a little bit that there seems to be a higher response rate there. Now, do these responses matter in terms of survival? And the answer is perhaps, but very, very little. This is an analysis we published some time ago on the right and here on the left from the German group. And you can see there is perhaps, the darker curve here are patients who did not achieve a complete cytogenetic. We know those patients do worse. If you look at the patients who did achieve a complete cytogenetic response, there is a bit of a trend for better survival when you get to the deeper molecular response. Similar to what we published also in a similar group here, the deeper the response, the better. But this is failure-free survival. We did not find a difference in overall survival. So I don't think it improves the overall survival that much. I mentioned earlier already, that is why you don't see a benefit in survival with second-generation TKIs. But there are other benefits. And to talk about these, I'm going to show you the data of the Tidal study. You remember the Tidal study was done in Australia. These were patients that were initially treated with Imatinib, and if they did not meet certain endpoints of response at early times, they were switched to initially increase the dose of Imatinib and then switch to Nilotinib. The results are outstanding. Look at the major molecular response at 24 months, 86%, MR 4.5, 60%. So very good results. And of course, excellent overall survival and transformation-free survival. Now let me go back to these MR 4.5 rates. On the top, you see the same graphics that I showed you earlier. At the bottom, I'm showing you three new panels. The first one is all Imatinib patients. And you can see here that by 5 years, it's 32%, very similar, the 32%, very similar to what I showed you already for the control arm of the ENESTnd and the decision. But look at what you have on the Tidal. This is Imatinib, remember. By 5 years, it's over 60%. Look at the MD Anderson. It is much higher, and particularly, I want to highlight the higher doses of Imatinib, which is this black curve. It's nearly identical to what you expect with Nilotinib or Dasatinib, which is also what you see on the Tidal. One important difference is that these two studies, the Tidal and the MD Anderson, are using higher doses of Imatinib. So I think that it is possible that using higher doses of Imatinib, you get similar response rates as you get with second-generation TKIs. Now, the question is the toxicity, and you do get more toxicity, but you get more peripheral edema, and you get more muscle cramps and things like that, not more arterial occlusive events, which is what you see with the second-generation TKIs. So my conclusion to this is that there are going to be many patients that, for one reason or another, are going to be treated with Imatinib. That's all they have available. These patients can do very well, but if I'm going to use Imatinib, I'm going to use it at higher dose. All right, so I talked earlier about the sustained major molecular, the sustained deep molecular response, sustained MR 4.5. I already talked about these rates, 40% versus 26%. This is with Nilotinib. That is important because those are the criteria that you need to consider treatment discontinuation. This is the long-term follow-up data for the for the STEAM trial, the French pioneer study on treatment discontinuation. And now keep in mind, this curve looks lower, 40%, because for that initial study, a failure was considered the reappearance of detectable transcripts. If you use the modern definition, which is the loss of major molecular response, it'll be around 60% rate of treatment-free remission. When you look at the data from the EuroSki, these studies has a couple of important characteristics. Number one, it's the largest study. But number two, to increase the number of eligible patients, they relaxed the criteria. It required only MR4 and only for 1 year, sustained for 1 year or longer. So with that, you get many more patients eligible. And they claim that the results are very similar to the STEAM. But when I looked at the two results side to side, here on the left, the STEAM, the follow-up study of STEAM using MR 4.5 sustained for at least 2 years. And then on the right, the EuroSki. If you draw a line, you can see that at 2 years, the response, the TFR rate is better with the STEAM. And two, you see more of a plateau, whereas on the EuroSki, you see this curve continues to go down. So I think that, yes, you do get more patients if you use the EuroSki criteria, but the success rate is lower. So in the end, you're going to be about the same in terms of successful treatment-free remission. One thing that I want to bring up is the fact that when we looked at our data at MD Anderson, we had a very similar TFR rate, 52% for these patients. But the one thing that stands out is that for patients who maintain their deep molecular response for at least 6 years, look at how much the loss of response of MMR drops after 6 years, from 60 to 70% of patients losing the response to only 6 to 15% of patients. So in my opinion, the ideal time to stop therapy is when you have a deep molecular response sustained for at least 5 to 6 years. It takes longer, yes, but then the success rate is significantly better. Now, not everybody gets to those deep molecular responses. We already showed that at best 10 years with the ENESTnd, for example, you get 60% that achieve CMR. So there was this randomized study, ENEST-CMR, looking at patients who have not reached that while on imatinib, randomized to either change to nilotinib or continue imatinib. And the primary endpoint was the achievement of a complete molecular response at 12 months. And both that and the 24-month are significantly better than with continuation of imatinib. But you pay a price. There are more patients who discontinue therapy because of adverse events, and you get more cardiovascular adverse events, a 6-fold higher rate of myocardial infarctions and things like that. So you need to think very seriously about this if you want to do this to your patient. Remember, these patients on imatinib were doing well. They didn't have a complete molecular response, but they were doing well. So it is important to take that in consideration. This is a single institution experience in France with a very long-term follow-up that was presented at ASH. And I want to highlight this study because it showed something very important, that we continue seeing relapses late. After 2 years, you see 14% of all the patients who lost their response lost it after 2 years. So that is important because that highlights that we cannot stop monitoring our patients. And another important study that was presented at ASH, this was the discontinuation of second-generation TKI. The results were good, but what I want to highlight is this one patient that the loss of response was in blast phase. And we had just published one other patient that also lost the response in blast phase. So although these things are not common, we need to keep in mind that occasionally a patient may not just have an increase in transcript levels, when you stop the TKI, but they may go to blast phase. Again, emphasizing, number one, the need for continued monitoring, and two, fully disclose all the potential risks to our patients so they're aware of everything that could potentially happen. So my approach to TFR is as follows. I like to say that I stop therapy before I even start therapy. What do I mean? From the beginning, you have to educate your patient and plan for aiming for the best outcome, monitoring closely, managing your patient very well. I prefer to stop when there's a sustained MR 4.5 for at least 5 years. I monitor very closely, of course, resume if there's loss of MMR, but I never stop if a patient has ever had a blast phase or a second-line TKI. So if we analyze the data, we have an unfulfilled promise for treatment-free remission. One, I already told you that only a subset of patients reach that sustained deep molecular response. Even with the second-generation TKIs, it's only about 40 to 45%. And two, that about half of those patients, when they stop therapy, are going to lose their response. That means that TFR is effective only in about 25% of all patients. So we are going to have to find ways to improve on both the number of patients who are eligible, but not by relaxing the rules, but by improving these patients who get to this point and decreasing the rate of relapse. I already told you about ENESTnd, so I'm not going to repeat that, but that is one possibility to increase the number of patients who get to these deep molecular responses. What I want to show you is, let's bring back this graphic, and if we take an SCMR of the 74 patients that are treated with imatinib, if we were to give them nilotinib, about 25% of the patients will have a deep molecular response after the switch. That means that 18.5%. If you add these to the patients that already had them with imatinib, you will end up with about 45% of patients who get deep molecular response. So it's a similar number of patients that will get to that point if you start with nilotinib, or if you have them on imatinib and then switch to nilotinib if they did not reach the deep molecular response. Other approaches that are being tested is add a second drug. I'm not going to go into the mechanisms, you know them well. We did a little experiment with ruxolitinib add-on because there seems to be a dependence on JAK2 in the leukemic stem cell. As you can see from this graphic, nothing very exciting there. We added azacitidine to some of these patients, and we did get a good response, but it is difficult to do it because it's subcutaneous. Now with a new formulation with the oral that's been shown to be effective in AML, maybe we can revisit this potential. We are combining asciminib with other TKIs. There is a Novartis study called the Ask for More about to finish enrollment, and there's the MD Anderson study with the other TKIs. These are patients who are doing well, but not yet in deep molecular response. In Europe, they are adding interferon. This is the Tiger study from Germany. From the beginning, they randomized patients to receive nilotinib alone or in combination with PEG interferon. If they have a confirmed major molecular response, in the interferon arm, curiously, they stop the nilotinib, continue the PEG interferon. If they have a sustained MR4, like the Euroski, then they do treatment discontinuation. And what you see here is that by adding interferon, maybe you get a little bit of a faster response, but in the end, you get to the same time point, to the same rate of response. So it doesn't seem to be a big advantage there. Whether it will improve the ability to maintain the response after treatment discontinuation, that will have to be, need more time. And this is the Australian data. It's a single arm, but also nilotinib in combination with pegylated interferon. And you see that the rates look very impressive. Look at the rate of MR 4.5. By 3 years, they're reaching 50% of patients. So if you put these two studies here and look at what's been achieved by other studies, it does appear that compared to, for example, ENESTnd, you get a higher rate of of the MR4.5s at 2 years when you combine with pegylated interferon. But if you look at the data from MD Anderson, we actually get the same rates with single agent dasatinib or nilotinib. So I am not sure that adding interferon will be very valuable. Very quickly, I want to touch upon the issue of quality of life after treatment discontinuation. And in my opinion, the results have been disappointing. This is the one US study looking at quality of life, and the fatigue, a lower number is better. You see there's a little bit of an improvement, but it's very modest improvement in fatigue, and then there's a plateau. It doesn't continue to improve. Other measures of quality of life actually, after initial improvement, they actually start getting worse again. And in other studies, the ENESTnd and these other studies, you see that most of the quality of life measures remain pretty much flat. So not much of a benefit. So we have looked at the optimal timing of transplant, because that is still an option. And this study was just published in the Leukemia and Lymphoma journal. This was just published a couple of days ago. And we compared the data from patients treated with TKI at MD Anderson with the IBMTR database. The bottom line is that the residual life expectancy is better for patients in chronic phase if they receive a tyrosine kinase inhibitor. In accelerated phase is equivalent, and in blast phase it's better for transplant, although it's very poor anyway. And we had published the same thing for patients with T359, but here using the ponatinib data compared to the European bone marrow transplant registry, but essentially the same. Chronic phase ponatinib is better, accelerated phase the same, blast phase transplant is better. I'm going to give you a few words about the arterial occlusive events. When you look at the randomized studies of nilotinib, dasatinib, or Bosutini against imatinib, you can see that at least for cardiovascular and cerebrovascular, nilotinib and dasatinib essentially doubled the risk compared to imatinib. So you need to be aware of the risk of these events with nilotinib and with dasatinib. Bosutini has less of these risks. So in patients with these risk features, that may be the preferable second generation TKI. And I'm going to skip this for the sake of time and go to my conclusion, which just to emphasize that we have excellent results with the established therapies, with all of them, including imatinib. There are some promising new treatment options coming, and the TFR is definitely an option that is established. But you need to be aware of the late relapses, the modest improvement in quality of life, the possibility that an occasional patient may relapse in blast phase, and importantly, the fact that it's only a reality for 25% of the patients. So we need to improve on that. And the transplant are usually reserved for patients who have failed 2 or 3 TKIs, and always keep in mind the arterial occlusive events. So Karl Popper, a scientific philosopher, said that science may be described as the art of systematic oversimplification, which I think is what I've done about CML during this presentation. So I'll stop here and I thank you for your attention.
Thank you, Dr. Cortes. That was an eye-opener. We heard so many talks on CML, but this was outstanding. Such phenomenal new data you showed us. We learned a lot. We can go to the second lecture and then have the questions during the panel discussion.
Perfect. Okay, and can you see my title slide?
Yes.
And it's a correct one, huh? Dasatinib?
Right.
All right. Give me a second. Let me just make a quick arrangement here. Okay. We're going to talk a little bit about dasatinib. We mentioned some aspects in the previous presentation, and I already mentioned the benefit in the life expectancy of patients treated with proper therapy, and the problems that we see even in the United States when you look across the board. Let me start by showing you the data with imatinib, the first TKI that made it into frontline therapy, where we recently saw the 10-year follow-up. And you can see that with the 10-year follow-up, the results in terms of response we knew were outstanding. Look at the rate of MR 4.5, 63%. That is very good. I'll show you the German data. We have the same with the Irish study. But look at the survival data. There was a tiny benefit in overall survival, even though the response rate was dramatically different. And that's what I was mentioning earlier, that you've already reached an excellent survival with imatinib. It's going to be very hard to improve on that. But when patients lose their response, when they become refractory, and this is old data, when they became refractory to imatinib, you can see how that survival curve, even in the chronic phase, drops significantly. By 4 years, it's only 65% survival rate. Very similar to what it was before we have tyrosine kinase inhibitors, the survival for chronic phase patients newly diagnosed. So that created the interest in developing strategies for patients who were losing the response to imatinib, and triggered the development of the second generation TKIs. I'm showing you here the 3 that have been approved. But of course, the focus of this presentation is going to be on Dasatinib. So I'm going to show you some of the very early basic principles of Dasatinib, because I think they're valuable now that we know a whole lot more about Dasatinib, and refresh our memory about a few things. Number one, the impact of the different survival. We've learned very early on that it was effective against most of the mutations, but you can see that it is not the same against all the mutations. For example, this is the wild type or the non-mutated BCR-ABL. It requires one of the lowest concentrations of Dasatinib for inhibition. And you see that some of these other mutations are inhibited, but they need probably twice as much Dasatinib. We know some of the mutations that you really cannot inhibit well with Dasatinib, notably the F317L, and of course T359, where we know Dasatinib has no activity at all. Next, let's look at the PK. If you remember, Dasatinib has a very short half-life, and you can see that here on this graphic. And actually, if you recall, the initial approval of Dasatinib was for a twice-daily schedule. In the chronic phase, the initial approval was 70 milligrams twice daily. Because of this PK that shows that the median half-life is about 5 hours. So when you did it twice a day, you prevented the concentration from falling below this threshold red line that represents the effective concentration. And that is not only the concentrations, but look at what happens with the inhibition of the kinase when you do once a day versus twice a day. Even when you look at the highest concentration, the 140, those that we don't use in chronic phase anymore, you can see that when you do it once a day by 8 hours, you're starting to see the kinase reappear, and by 24 is back to baseline. Whereas if you do it twice a day, you see a more sustained inhibition of the kinase, and it actually improves by 24 hours. So clearly, the kinase inhibition requires a twice-daily schedule. Yet we are doing it. Well, one of the things that helped convince us that once a day was perhaps appropriate is this in vitro study. These studies look at the significance of both the concentration and the time of exposure for both imatinib and Dasatinib. I have highlighted here the concentrations that you can reach in the clinic, 100 milligrams for Dasatinib. You can see that when you use the high concentrations that you need, even for a very short period of time, the viable cells are essentially gone. So even though you have a short inhibition, because of the potency of the drug, it is enough to decrease the number of viable cells and maintain that for a long period of time. That is not the case with imatinib, unless you go to very high concentrations that you cannot achieve in the clinic without significant side effect. So it showed that a very transient inhibition with dasatinib, either because of its potency or because of the other kinases, SARC or others that it can inhibit, was enough to produce the same effect, and that changed the perception of the dose that you need to give, and I'll get back to that in a minute. So that led to this randomized study where patients that had failed only imatinib were randomized to 4 different schedules of dasatinib. The standard at the time, 70 milligrams twice daily, or 50 milligrams twice daily, or the once daily equivalents, 100 milligrams once daily, 140 milligrams once daily. And the summary of the results are what you see here, and you can see the results are very good. I already told you about the complete cytogenetic response. This is resistant plus intolerance, a little bit better with intolerant than with resistant. But it also showed that the survival, according to the schedule, was identical. They all got pretty much the same levels of response. But we saw significantly less pleural effusion and thrombocytopenia in particular with the 100 milligrams once daily compared to the other schedule. So that made this schedule of administration the standard for dasatinib. We, of course, also did studies with the advanced stages, accelerated phase and blast phase, myeloid or lymphoid or even Ph-positive ALL. And you see the results. Now, keep in mind, in these stages, the focus was the major hematologic response. And you can see these, they're very higher in accelerated phase, and then it goes down some. Although the rates of cytogenetic responses are higher in the lymphoid malignancy. And that is because SARC inhibition seems to be particularly relevant in lymphoid diseases. Now, the rate of cytogenetic responses is higher than the hematologic because the myelosuppression, thrombocytopenia, etc., prevented us from calling this a complete hematologic response, yet the patients achieved a cytogenetic response, which is even more important. The progression-free survival is dependent on the stage of the disease. Excellent for chronic phase, and then it drops down in accelerated phase, so it's still very good. But in blast phase and in ALL, as you know, we need combination therapy to have more sustained response. Well, because of the success rate in the advanced stages and after imatinib failure, because we were starting to see that some patients treated with imatinib in frontline could do better, we started with a frontline approach for dasatinib. And we actually did the very first study of dasatinib frontline therapy at MD Anderson. This study started in 2005, a couple of years before the Decision study started. We just very recently published a very long-term follow-up results of these analyses, of this study. You can see the median follow-up is 6.5 years because patients were still continuing to be enrolled up until 2 years ago. But you can see here that more than 60% of patients are still receiving dasatinib. If you remember on the ENESTnd, at 10 years, 50% of patients have stopped therapy. In the Decision and in the ENESTnd, at 5 years, 40% of patients have discontinued therapy. More of our patients continue on therapy. So I think you can have many more patients remain on therapy than has been reported in those other studies if you manage the patients well. All right, so here are the response rates, and you can see very high rates of complete cytogenetic response. Look at 1 year, you have 93% complete cytogenetic response. 75% major molecular response, already almost 40% MR4.5. Now, remember that the decision at 5 years had only about 42% or something like that MR4.5s. In our hands, this reaches in excess of 60%. So if you manage your patients well, it can be significantly high. Of course, we know pleural effusions are a factor, and I'm going to get back to these later. But these are just the graphics of the cumulative rates of response. Look at how quickly the complete cytogenetic response rate goes up almost to more than 90%. Look at the rates of the deep molecular responses, very high, very early. So excellent result. Now, that, of course, led to the Dasatinib study that you know well. We've already talked a little bit about that, the randomized study of Dasatinib versus Imatinib in newly diagnosed patients. Unfortunately, this study was terminated after only 5 years, but that still allowed us to see that you could get a higher rate of responses, you could get deeper responses, faster responses. Look at the rates of less than 10% at 3 months, 84% versus 64%. Fewer transformations, 4.6 versus 7.3. But as I already emphasized, no benefit in overall or progression-free survival. We talked already about the rate of MR4.5 over time. On the left here, you see also the MMR at 5 years, which is still significantly better. And one important thing that you notice is that these curves are not merging. At least up until the 5 years of follow-up, the separation remained very significant. This is the overall survival and progression-free survival in more detail. Again, no significant difference. Now, there have been other randomized studies of Dasatinib against Imatinib. One of them is the SWOG study, very similar in design. And you can see here the primary endpoint was molecular response at 12 months. MMR was significantly better with Dasatinib. The MR4.5, it was not statistically significant, but there's already a benefit, and this is only at 12 months. And you can see overall everything following the same as the decision. And actually, if you put them side to side here, decision and the SWOG study, and look at the 12-month outcomes, very similar data. So very reproducible benefit of Dasatinib compared to Imatinib in these two very independent studies. Importantly, the SWOG is more of a community approach. So even then, very good results. And the third study is the SPIRIT-2. This was done in the UK. A very large study, 800 patients. Now, the primary endpoint here was event-free survival at 5 years. And that, of course, was not met. That did not show a significant benefit. But everything else is better with Dasatinib as expected. The complete cytogenetic response, the MMR, look at the MR4 at 5 years, almost 80%. Look at the early molecular responses, 94% with Dasatinib. So everything in line with what we saw in the other studies. So very reproducible data in 3 randomized studies. And then, of course, I already showed you the single-arm study from MD Anderson that looks even better in this regard. Of course, that's a single institution and has other features. Now, one of the issues that we've noticed a long time ago was that we were getting a lot of patients reduce their dose very early. And, about 15 years ago, I started trying to do a study with lower doses of Dasatinib, which we were finally able to conduct and do. And we started doing this about 2 or 3 years ago at MD Anderson, and using Dasatinib 50 milligrams as the starting dose. And you can see here the results recently published. Very good results. Look at the MR4.5, for example, at 1 year, 50% of patients. Very few patients have reached the longer follow-ups, but that continues to increase over time. So if you put these side to side with the So the Dasatinib 50 milligrams are the green bars here. And then the blue bar is Dasition, 100 milligrams. The orange bar is MD Anderson, 100 milligrams. And you can see that the results are probably comparable to what we had with 100 milligrams at MD Anderson and better than the Dasition study. So it looks like these lower doses of Dasatinib can be effective as the 100 milligrams daily dose of Dasatinib. Of course, they have never been compared head to head, but it is not surprising because we know from the ENESTnd that lower doses of Nilotinib than we use in salvage are equally effective. We know from the two studies from Bosutini, the first study, you may remember that Bella study with 500 milligrams, and then the subsequent BFORE study, both in Frontline, the 400 milligrams was equally effective at the 500. So these results are essentially the same with Dasat. We have done a chart review worldwide analysis in this study that's called the Simplicity. So this is like a registry data. But one of the things that we were interested in is how are people using Dasatinib in the community? Are they using it as prescribed, as labeled or not? So you see here, there are 406 patients treated with Dasatinib with a once daily schedule. There are some patients that were being treated with a twice daily schedule. And I don't know why anybody would do that today, but we excluded those from the analysis. And among the patients that were using it once daily, we wanted to see what was the starting dose. And as you can see, there were a number of patients, 25 patients that were started with a lower than 100 milligram daily dose, and a handful of patients that started with a higher dose. Some of the reasons can be seen here. You can see that the median age for the patients that started with a lower dose was almost 20 years higher than the patients that started with the median, with the standard dose. And the other thing is that seems to be more frequently done in Europe than in the US. You see, and there's small numbers, of course, but it represents 14% of all the patients treated in Europe, whereas only 3% of all patients treated in the US used the lower dose. Now, so what happens for the patients that started at 100 milligrams once daily in terms of their dose over time? As you can see, there was a significant number of patients who had a dose reduction, a third of the patients. Now, that means that most of the patients can maintain the standard dose, so that's important. Of the patients who did a dose reduction, half of them did it between the start of therapy and 6 months. And then after that, it's almost equally distributed, although it is interesting that the next largest group is after 24 months. 20% of patients did their dose reduction after 24 months. Now, there was a study in the UK doing a more intentional dose reduction. So this is called the Destiny study. These are patients that are treated with a frontline TKI for at least 3 years. And if they've had a BCR-ABL of less than 0.1%, they were intentionally dose reduced. Now, most of these patients were receiving Imatinib. There were a few Nilotinib and a few Dasatinib. But look at what happens. If the patients had achieved a major molecular response, 20% of them will relapse. But if they had achieved an MR4, only 3% of these patients will relapse. So that means that the patients who have already a very deep response, if you lower the dose, most patients will be able to maintain their response. And that is important information to keep in mind in the clinic. So now let me talk about another important study and another important area. These are now the 2020 ELN recommendations, and I'm showing you here side to side with the 2013 ELN recommendations. I'm highlighting the 3-month mark. Remember, in the 2013, more than 10% transcripts at 3 months was called a warning. Now that remains, but in the 2020, they say that if it's confirmed within 1 to 3 months, it is actually a failure, not just a warning. Now that requires confirmation. And it's 1 to 3 months, so essentially it takes you all the way to 6 months. Why is that? Because we know that those patients have a lower probability of overall survival and event-free survival. You see here on the left, this is the overall survival. It drops from the mid-90s to around 80% for the patients who have more than 10%. The event-free survival is similar difference. Now, I want to highlight the fact that although there is a statistical difference, the difference is small. Keep in mind that 80% of patients are still going to be alive. So the majority, the great majority of the patients are still going to be alive. It's better if they were less than 10%, but it is still good if they're more than 10%. That we know now is not only for the front line. I'm going back to the Dasatinib after imatinib failure. And this is what happens with the response at 3 months in the second line therapy. And again, if you get a less than 10% at 3 months, you are much better than if you are more than 10% at 3 months from the start of therapy. So back to decision. This is what we found. On the left, you see the Dasatinib. The first thing that you can tell is that there's many more patients who reach that less than 10% with Dasatinib compared to imatinib, 84% compared to 64%. So it's good with imatinib, but it's certainly better with Dasatinib. Now you can see that if you get to less than 10%, the probability of reaching these deeper molecular responses is the same, no matter whether you achieved it with Dasatinib or with imatinib. The difference is that you have many more patients in this category, in this good category with Dasatinib than with imatinib. And this you see graphically here, again, the rate of MMR, MR4, and MR4.5 according to the response. Now the question is, do we need to change at 3 months? And we did this analysis some time ago. We've never changed at 3 months at MD Anderson. And we said, well, so since we never changed, what happened at 6 months? What was the outcome? Now, I'm not calling here less than 10% because back in those days, we were not doing PCR regularly at 3 months. But the major cytogenetic response is the cytogenetic equivalent to 10%. So these are patients who at 3 months did not achieve a major cytogenetic response. We continued therapy. What happened at 6 months? So the patients who by then achieved major cytogenetic response, look at their outcome. It's almost the same as if they had achieved it by 3 months. If they still do not have the major cytogenetic response, then the difference becomes larger. But still keep in mind that still the majority of patients are doing well. Almost 80% overall survival, 66% event-free survival, lower than the good responders, but it's still not a terrible outcome. Now, one of the problems we had is that we have had very few studies looking at the intervention, what to do for these patients. And the first study that was done on these was the LASOR study. Now, I have to warn you that this study was designed based on the 2006 recommendations from the European Leukemia Net. And that did not speak about the 10% at 3 months. So different criteria. And the design was to continue imatinib or change to nilotinib. And you see that there was a benefit of changing to nilotinib. The difference was small and not statistically significant because of the crossover. But if you adjust for the crossover, the differences become more significant, as you can see here on this slide, both for cytogenetic response and for major molecular response. But that led us to design a study with Dasatinib with the 2013 recommendations from the European Leukemia Net. So these are patients who at 3 months are not achieving the 10% while on imatinib, and they were randomized then to receive dasatinib or to continue with imatinib. The primary endpoint was measured molecular response at 12 months, and as you can see clearly, we got better results with dasatinib than we continue with imatinib. Sure enough, some patients with imatinib will continue to improve. You see here on the right that cumulative incidence, but with dasatinib that is better, and the curves continue separated up to the time of the follow-up that's available for the study. Now, that did not change the overall survival. That did not change the progression-free survival. They're already good. I was emphasizing that. They were already good with imatinib. So I think the main point here is going to be the long-term follow-up to see if we see a benefit in the MR4.5 rates and those other endpoints that are important for treatment-free remission. I'm going to skip that one and go to the treatment-free remission because that is, again, the potential benefit that we can expect from this early suite. But in addition to that, most of the data that has been generated with treatment-free remission, with the discontinuation, has been, for obvious reasons, with imatinib. But we now have some studies looking at dasatinib. And these were the first two studies, the DSTOP on the left and the DADI on the right. They were similar but not identical. On the DSTOP, they considered a deep molecular response as MR4, but they required 2 years of MR4 before stopping, whereas the DADI required only 1 year before stopping. You can see that here on the slide. You can see the results look better with the DSTOP than with the DADI. And the one difference that I see is the duration of the consolidation after reaching that deep molecular response. So that may suggest that 1 year is not quite enough, as I already mentioned in the previous presentation. Remember I told you about the DESTINY study. That was the study of decreasing the dose intentionally once the patients achieved an MMR on MR4. Well, the second part of the study was to stop therapy. And if you stop therapy when the patient only has MMR, you see that the success rate is much lower than if you stop therapy when the patient has achieved an MR4. So that further emphasizes that the deeper the response and the longer the duration, the better. But let me get back to the studies of treatment discontinuation with dasatinib, because now we have this study that was a prospective study where patients were screened if they had dasatinib for at least 2 years as first line or as second line, and if they had a dasatinib-induced deep molecular response for at least 1 year, then they had to confirm it, and then they discontinue therapy. So, you know, a very straightforward design, and these are the results. You can see here the success rate is about 50%, similar to the others, maybe a little bit lower because I think the duration was not enough. But essentially, you still see a good duration of a sustained response after treatment discontinuation. Keep in mind the follow-up is short, and I already told you relapses can happen late. Also important that the success rate is better in the first line if patients are taking dasatinib in the first line than if they're taking it in subsequent lines of therapy. So it's important to keep in mind. Now, for the patients who lost their response, if you reintroduce the dasatinib, essentially everybody gets back to MMR. The blue part of each of these bars represents MMR. The red part represents loss of MMR. These are only the patients who lost MMR. And you see the red part is very short. Very quickly, patients recover their MMR. It's only one patient who was lost to follow up. So we cannot say that this patient did not recover MMR. We just don't know. I want to bring to your attention this study that was done in Canada, where they discontinued therapy. And again, the criteria was, now these was patients who had Dasatinib second line after Imatinib failure. They used an MR 4.5 after 12 months. The success rate here was low. 84% of patients lost the response after the second TFR attempt. This is second TFR attempt. Most of the studies have shown that the success rate is around 30 to 35%. And I think that the main reason why the success rate here is so low is because they only required 12 months of MR 4.5. And for a second attempt, I think that's definitely way too short. Let me move now to the safety. I think we all know Dasatinib is, generally speaking, a very safe drug. In the randomized study against Imatinib, there are a few things that were significantly better with Dasatinib, actually. Less peripheral edema, less muscle spasms, less nausea and vomiting. Of course, we did see the pleural effusion in 28% of the patients. Very rare with Imatinib. It happens. Keep in mind that it can happen with any TKI, but more with Dasatinib. Pulmonary hypertension, again, more common with Dasatinib. So those are the common findings. Let me mention a little bit more about the pleural effusion. This was one of the earlier studies that we published on pleural effusion. And the one thing that I want to highlight is that on a multivariate analysis, we found that patients that had a cardiac history of hypertension, or receiving a twice daily schedule had a significantly higher rate of pleural effusions. Also, that we found that these patients had an elevated right heart pressures, suggesting pulmonary hypertension. So that was the first mention of pulmonary hypertension in Dasatinib. So in Decision, this is what happened. I already told you 28% of patients had a pleural effusion, but very few discontinued therapy because of pleural effusion. You do need to stop therapy, sometimes adjust the doses to decrease the recurrence rate. But with that, most patients can be retreated. And this is a manuscript that we wrote with some guidelines as to how to manage pleural effusion. I'm not going to go into detail of that. It might be an interesting read. You have the reference here just to help with the management of these patients that develop pleural effusion. And so let me then now talk about the arterial-occlusive events. Keep in mind they do happen with Dasatinib. I already mentioned that the probability of these events occurring with Dasatinib is more than twice as much as with Imatinib, particularly for the cardiovascular, that means a heart attack, angina, etc., or for cerebrovascular, TIAs and strokes and things like that. They did not report peripheral arterial-occlusive disease, but it does occur. We've seen it for sure, so that also can happen. I already showed you this, how this is very similar to what we see with Nilotinib. And in the analysis that we did at our institution using Imatinib, Nilotinib, Dasatinib, or Ponatinib as frontline therapy, these are not randomized studies. Certainly the risk is highest with Ponatinib, but Dasatinib and Nilotinib essentially double the risk compared to Imatinib 400. So keep that in mind. Also, it's associated with the number of risk factors that the patient has. So the more risk factors the patient has, the greater the risk of developing these complications. What that means is that if you're going to treat a patient that has diabetes and hypertension and high cholesterol, you need to control those risk factors so that the risk of these events is lower. And this is a meta-analysis of many studies just emphasizing Dasatinib, Nilotinib, and Ponatinib a significantly higher risk compared to Imatinib. Briefly, a couple of other adverse events. We have shown that Imatinib decreases the glomerular filtration rates in patients that are taking it long term. We do not see that with Dasatinib or with Nilotinib. We do see it on the right with Bosutini. Also keep in mind that Dasatinib may have an effect inhibiting platelet aggregation. You see that on the left. We do not see that with Imatinib. We do see it with Ponatinib, by the way, very similar to Dasatinib. And you know that some patients with Dasatinib experience bleeding, so keep that as in mind. This is the quality of life measures. We did prospectively on patients taking Nilotinib, Dasatinib, or Ponatinib as frontline therapy. We had a study of Ponatinib for a short while as frontline therapy. And you can see how the fatigue, which is one of the most troublesome problems, actually is the least affected with Dasatinib than with Ponatinib, which drops down more. And then with Nilotinib, it drops and then it stays there, but it doesn't recover. So that's another interesting observation. So in conclusion, I think Dasatinib is a drug that works in the continuum of care of CML. So when you start a patient with treatment, you start trying to go to the progressively to better responses up to the point to the TFR. Certainly, who patients who develop resistance or intolerance have to change therapy. We obviously have patients that have suboptimal response or warning, and some patients that may have low-grade toxicities. And then we have patients that do not reach complete molecular response, and we've been trying to see what to do with those patients. We talked about the ENESTnd, for example. Among the patients who develop resistance, some patients develop advanced phase disease. Well, in all of these stages, you can use Dasatinib and the frontline setting. I told you about the different randomized studies as well as the MD Anderson study, including the one with the lower dose. When patients develop resistance, certainly Dasatinib is a very good drug, as well as when the patient develops intolerance. In the warning, the only study that really has addressed these in the current definition of warning is the Discern study, and so far looks positive in terms of the MMR. I emphasize we need a longer follow-up, and we do have prospective data now for TFR, as well as retrospective data with the DADI and the DSTOP for showing that the TFR with the Dasatinib applies the same as with any of the other tyrosine kinase inhibitors. And certainly in the accelerated and blast phase, it can also work, although in blast phase we prefer to use it in combination. So Dasatinib then, in conclusion, is a very safe, a very effective drug in all stages of the disease. Like all TKIs, it needs attention for the potential adverse events, but we have very long-term experience, and with careful monitoring and good patient care, most of the patients can continue on therapy throughout all the way until they get to TFR, or if they have to stay on therapy. You can use those adjustments when necessary to help with the management of the potential side effects. There are still some questions. What is the right dose at the frontline? What is the right timing? For example, should we start with that, use it after 3 months only for the patients who are falling behind, only after failure, etc.? What are the right patients? What about the patients with a lot of comorbidities and risk for pleural effusion, etc.? And still some understanding of the biology, because we don't understand what the SRC inhibition means and the PDGF and all of that. So we still have some questions that we need to address. So just like I did before, I'll end with a quote, this one by this philosopher Voltaire, that since I told you that I have still some questions about Dasatinib, he said, doubt is not a pleasant condition, but certainty is absurd. So I am not certain about many things still in CML. So I'll stop here, and I thank you for your attention. I'm sorry, this is my old email address, but I already showed you the current one. Thank you very much.
Thank you, sir. You are a master. What you did in these 90 minutes is phenomenal. As I said, after your first talk, I'm going to repeat the same thing. We have heard CML so many times, but nothing what we heard in 90 minutes. This was superb, and that's why probably everybody was waiting for you to deliver these talks. We have waited for quite some time, probably a few months and few years, but then at the end of the day, you made it. And though everybody cannot clap for you, but those who are here, I'm going to clap for you, and I request all my faculty over here to clap for you.
Thank you.
Thank you. Thank you, sir. Thank you. Thank you. Thank you. Faculty who is here, if you have any questions for Dr. Curtis? Dr. Rahul? Sharad, Dharma, any one of you?
Yeah, Sharad here, sir. So any experience with the low-dose Dasatinib, Dr. Cortes? Because that's something which we are looking at in our Indian scenario, the low-dose Dasatinib data.
I showed you briefly the data of the start with 50 milligrams daily, and it looks very effective. I think for the frontline setting, 100 milligrams, of course, works well, but I think 50 milligrams is probably enough. So the data that I showed you looks very, very positive. The follow-up is short, but I have no reason to believe that it'll look any different with longer follow-up. I think it'll be fine.
Right.
Thank you, Dr. Cortes. Others?
Yeah, sir, I have a question.
Go ahead.
Actually, this is a very pertinent question, sir. In recent times, actually, the patient's COVID positive patient, first diagnosed CML, I have encountered young patient. I planned for Dasatinib, but incidentally, patient diagnosed with COVID-19. So, what is the best drug for this patient at this moment when the patient is having count of 3 lakhs, huge splenomegaly, first diagnosed with CML-CP? So, what is your suggestion? I started with Imatinib. I don't know whether I am right or wrong.
Well, you're right. I mean, it's a good option. We have been collecting data through the International CML Foundation from colleagues from all over the world, trying to understand these kind of questions. What do you do now that we have this serious health problem all over the world? Although this is merely observational and from the reports that we received spontaneously, it appears that there doesn't seem to be any difference for or against any of the TKIs in terms of their safety or efficacy if they have the COVID-19. So it appears that using any of them is fine as you find appropriate based on all the features. We do not seem to see any higher risk of acquiring COVID-19 or of having a more severe manifestation of COVID-19 with one or with the other. Now, Imatinib is a good drug, so you did fine. But we've seen patients with any of the other TKIs do well.
Thank you.
Thank you, Dr. Cortes. Dr. Tufan, any question? Chandrakala?
Sir, what is the role of interferon actually? Because now we got many TKIs, and interferon is out of CML, or do we have? Does interferon still plays a role in CML management?
I am not too excited about interferon. Perhaps on a patient that has failed everything else, to consider it. But the studies that I showed from Germany and from Australia. To me, they don't look as impressive. You get more toxicity and you get more cost and you get more inconvenience because it's subcutaneous administration and all of that. And I do not see yet a benefit. The only caveat, the only question mark that I have, and which could help me change my opinion, is when they get to the point of starting to discontinue therapy in some of those patients. If the success rate of treatment discontinuation is better, if we have fewer patients who lose their response after treatment discontinuation, well, then it might be that it's beneficial. But even then, I would argue, do you need to use the combination from the time of diagnosis, or should you use it just for a year or two before you stop therapy and then stop therapy? That would save some years of administration to the patient, but that will have to be addressed with the study.
Dr. Tufan, sir, Arnold, sir.
Yes, Tufan, go ahead.
Yes. So when you consider the Bosutini first line in your patient, because the Dasatinib is there, the Nilotinib is there, the Bosutini, there is a short follow-up data is there. So did you ever consider the Bosutini as a first line in your patient?
I'm sorry, I didn't hear you well.
Patient profile for selecting Bosutini as the first line TKI.
Well, Bosutini seems to have the lowest risk of arterial occlusive events of the second generation TKI. I still think that Imatinib has less of a risk. But of the second generation, I think that Bosutini has the lowest risk. So that is one group that I think that clearly can benefit from Bosutini. If I want to use a second generation and I have a patient that has risk factors for arterial occlusive events, diabetes, hypertension, hyperlipidemia, smoking, whatever, I would definitely use Bosutini. Now, any other patient that you want to use second generation TKI is fine for Bosutini, but that is one area where you can differentiate perhaps a little.
Right. Pankaj, anything? Yes.
What is the role of BCL2 inhibitor venetoclax in CML?
What is the role of, I'm sorry?
Venetoclax.
Well, that's an interesting question. It has shown very nice synergy. One in the blast phase, and that could be valuable because, of course, in blast phase we don't have treatment. But also in eradicating the leukemic stem cell. That could perhaps be beneficial for patients who you're trying to get the treatment discontinuation to either make more patients eligible or decrease the risk of relapse. And some of the studies are ongoing on that. We don't have any clinical data yet, but there are studies ongoing.
Sir, is there any role of aspirin or any warfarin anticoagulants in patients on Nilotinib or Ponatinib?
Well, we've used it I guess out of need, but I think that the likelihood of them in benefit is low. Because the two drugs, well, Dasatinib and Ponatinib, they both inhibit platelet aggregation, which is why we use aspirin. So I think that there's probably very little that aspirin can add to that effect. Now, aspirin is fairly safe. Well, it could increase the risk of some bleeding, so I guess you could use it. But I don't know that it is effective, and one, there's no prospective data, and two, again, some of these drugs that have an increased risk of these events already have an aspirin-like effect on platelets.
So, Dr. Curtis, one question. The patient who achieves second chronic phase after second generation TKI, like Dasatinib, from the blast crisis came to second CP. Will you consider the stoppage of the Dasatinib if it's achieved the MR 4.5 for long period?
Absolutely not. A patient who has gone to blast phase anytime, I would never consider them for treatment discontinuation. I think that would be, unless there's prospective studies that demonstrate this, would I enroll that patient in a clinical trial? Yes. But that is one scenario where I don't think that it should be done outside of a clinical trial.
Dr. Curtis, wonderful presentation indeed. You presented some interesting thing about sequential TKI usage. Would you do that in your clinical practice?
Data on what, I'm sorry?
Repeat your question, please.
No, sir. The sequential TKI usage in chronic phase chronic myeloid leukemia, does it do it in his clinical practice?
Sequential use of TKIs.
Well, we do that in one way or another because of patients' toxicities or whatever. So I think we do it. I don't know if your question is in doing it, for example, starting with a second generation and then maintaining them with an Imatinib, for example, once they reach a deep molecular response. And that is an interesting approach that it hasn't been done prospectively. My guess is that it could probably work. and it'll save you, some money and risk for the arterial-occlusive event. It could have some potential advantages, but it hasn't been done prospectively. But again, if I had to guess, I think it could work.
Thank you.
Others, any questions? Yes, Pankaj.
Dr. Curtis, I have many patients on Dasatinib 150 mg and 100 mg upfront. I am encountering through one problem daily. A patient on 100 mg Dasatinib are coming with severe pancytopenia. Not only severe pancytopenia, but it is a long-standing pancytopenia for 1 month, 20 days to 1 month. We are doing bone marrow in between, but that is absolutely normal and hypoplastic, and patient recover after 1 month to 40 days or 45 days. So what is your experience regarding myelosuppression in Dasatinib 100 mg?
It certainly happens. It doesn't happen more than with the other TKIs. It happens same as everything else. Perhaps Bosutini has a little bit less neutropenia, but not thrombocytopenia. And remember, Bosutini doesn't inhibit SIK, so there may be some rationale there. But we do see that. Definitely, that's a patient where you may want to lower the doses. And one of the benefits that we've seen with starting with the lower dose with the 50 milligrams is precisely that you see less myelosuppression. But still, there's a few patients who have that product. The majority of patients that have myelosuppression, eventually over time it gets better. You can support them and eventually it gets better. But there's the occasional patient where it remains a constant problem and there's very little you can do. We have done a study using a thrombopag on patients that have chronic thrombocytopenia that they don't respond. We're hoping that it will be published soon, and it's currently under review. And it works very well. So for those patients where thrombocytopenia is an issue, a thrombopag is a good option.
And if patient recovers from the thrombocytopenia with a thrombopag, you go back to the same TKI or you will use a different one?
Well, usually, in most of the instances, I went to the same one because although cross intolerance is uncommon with TKIs, thrombocytopenia seems to be the one adverse event where there is more cross intolerance. The patients that have severe thrombocytopenia, they tend to have it with, most of them, they tend to have it with whatever else you give them. So I would probably go back to the same one. Curiously, in some of these patients that we included on that trial, we not only were able to get back to the same TKI, but in a few of them, we were able to go back up on the dose. So, maybe something to consider.
If a patient on Imatinib in a deep molecular response now shows rising creatinine, what's your approach? You sort of precipitated a treatment-free remission, or you change over to another one?
Well, yeah, it depends on the situation of the patient. If the patient is ready for treatment-free remission, meet the criteria, and the patient is interested, because not every person wants that. But if they have that, then yes, you can consider doing that and monitor closely as we would do with any TFR patient. But if you're not there, then you can either lower the dose or change to a TKI. And here I would select either Dasatinib or Nilotinib. So those are the ones that have, in our experience, the least effect on the kidney. Bosutini has some more similar to Imatinib.
Is there a consensus now about the Ponatinib dose? 30 or?
Well, we just presented the preliminary results of this study called the OPTIC trial. The OPTIC trial was randomized for chronic phase patients that had resistance or intolerance to 2 or more TKIs. And they were randomized to start at 45, 30, or 15. And the patients that started at 45 or 30 were required to go down to 15 once they achieved a response. And the response for this study was defined as a BCR level of 1 or less 12 months. And what we found is that the response rate is significantly higher with 45. It's 38% compared to 27% with 30 or with 15. 30 and 15 were identical. And that difference is particularly large in the patients that have T315I. The arterial occlusive events were a little bit higher with the 45, but the difference was very tiny. We had 5% with 45 and 4% with 30. So there was only a 1% differential in these events. So looks like the gap in efficacy is much larger than the gap in safety. So with that, I would say that particularly in a patient that has T315I or that has failed more therapies, in a more difficult situation, I would use 45. If the patient, but keep in mind that perhaps one of the things that helped us with the safety was that lowering of the dose once they reach a response. That may be the trick that we did not do initially with the early studies with Ponatinib, that intentional dose reduction once they reach a good response.
So there's a question about mutation analysis when a drug fails. Is Sanger's adequate, or you will go for NGS?
With NGS, you're going to find more low-level mutations. You'll find probably an additional 10 or 15% of patients with mutations. I still have a question about what does it mean to have a mutation at such low levels? Is it really the driver of the resistance? If it represents 1% of the total clone, is it really driving the resistance? So, I mean, right now in clinical practice, I still use standard sequencing, Sanger sequencing. In research, we are doing NGS, but in clinical practice, I follow Sanger sequencing.
Another question is, are there any mandatory indication to start second generation TKI upfront? Any mandatory?
Not mandatory. I think that you do it according to your patient's goals and things like that. I think any patient that may want to consider the possibility of treatment discontinuation, better to start with the second generation. There are patients who, particularly perhaps some of the older or more frail patients, that you just want to have as little toxicity as possible and have a longer life, and that's all. Imatinib is a good choice, and I think it's important to emphasize that imatinib is a good choice. But certainly you have a better chance of getting to a TFR with the second generation.
From same token, there is a question, is there an exact time limit for how long there should be deep molecular response before you suggest TFR? After imatinib, after Dasatinib, after Nilotinib, and after Bosutini?
Well, to me, the minimum is 2 years. Now, I showed you, Eurospeed considers 1 year, but to me, the results look very different. So the minimum I consider is 2 years. The optimal I consider is 5 years.
That's for each one of them.
It's the same for all. Curiously, once you reach that, it doesn't matter which one it is. You have a better chance with the second generation, but yeah.
There's one question about CML P190 variant. What will be your suggestion for the best treatment?
Those patients have a worse prognosis. I think that's a scenario where you may want to favor a second generation TKI, with the understanding that we don't have prospective data to show that they're better. They're not common, so there's been no real studies to show that they're better. Anecdotally, experience has been a little bit better, but it's anecdotal. So, but even then, that's what I would.
Right. Accelerated phase of CML. Will you go for transplant, or you will still try with TKIs only?
I would try TKIs, but I would start looking for donors. The outcome long term is about the same. Now, for a younger patient that has an excellent donor and all that, you know, if you don't get a good response quickly with a TKI, I think it's worth considering. But my first approach is TKI.
Another question is about TKI resistance. If no mutation is found, what is the next commonest cause?
You know, we became so obsessed with mutations that we forgot to look at other causes. So no, we are starting to learn that some patients have other molecular abnormalities that may be driving the disease together with, or maybe be the main drivers of the disease. You know, some time ago there was some talk about the transport of the drugs. That applies to Imatinib, but not to the other drugs. So we don't really understand the mechanism of resistance. And in some way, I prefer a patient with a mutation than with no mutation. Because if you have a mutation, you know what's happening, and perhaps another TKI will work. If I don't have a mutation, you know, for example, in the Post-Imatinib studies, if you look at the data, the worst responses are in patients that have no mutation, possibly telling you that there are other drivers of the disease that we don't know yet.
Right. Faculty has any other questions?
Dr. Cortes, how would you practically manage pregnancy in chronic phase CML?
Well, you know, we're also hopefully we're going to have our manuscript out soon. It's under review. I take a very minimalistic approach. And you can think here about three possible scenarios. One is the planned pregnancy. That's the easiest. You try to bring them down to the lowest possible PCR transcript level before stopping therapy for the pregnancy, and then maintain it off for the duration of the pregnancy. The next is the unplanned pregnancy. A patient is taking a TKI and becomes pregnant. I stop the TKI as soon as I recognize the pregnancy and monitor the patient. So for these two first scenarios, what if you start seeing that the transcript levels start going up? I don't do anything. I just watch them. You know, you only need 9 months. And if the PCR keeps going up, my experience has been once the baby is born, you reintroduce the TKI, they respond. So I'm not worried about that increase. I've only had one last patient during pregnancy. That was the one patient where one of my colleagues used interferon. I don't use interferon. And the reason for that is because although it has been mentioned that it's safe, it may be safe. Number one, remember that the responses to interferon take a long time to occur. The median time to a cytogenetic response, cytogenetic, was 12 months. For molecular response, so it's placebo for us, for the doctor. You know, we feel better, we're doing something, but it's not going to help. And you know, it has side effects, fatigue and depression, and all these things. And the most challenging scenario is the patient that is pregnant, and then you diagnose CML. Because then, of course, the disease is very active. So it's more challenging. What I do is I allow high white cell count. I mean, if the white cell count is 60 or 70,000, that's fine. As long as the mother is doing okay, there's no signs of acceleration or anything, and the baby is growing okay, I don't do anything. If there's too many symptoms, or the white cell count is going up too fast, or spleen or something, I use short pulses of hydroxyurea. It's more effective and more rapid to bring the white cell count than interferon. I don't keep them on hydrea all the time. I give them a few days, bring the white cell count down. Doesn't have to be normal, just down to the 20s or something, and then monitor. Now in the third trimester, you could use TKIs. If things start getting a little bit complicated, then you could use the TKI in the third trimester. It seems to be safe for the baby. So I've done that in a patient or two.
Thank you, Dr. Cortes. We're waiting for your manuscript on this.
Well, I'm responding to the reviewers. Hopefully it'll come out soon.
If the woman has come to you in second trimester and she's taken the TKI through and through all first 3 months, and she asks you for the opinion whether she should terminate the pregnancy or continue, what do you advise?
Well, in the second trimester, some of the fertility experts that I discussed this, it's safe already to do the TKI. So I don't feel as comfortable in the second trimester, but if the baby is growing well and has no obvious evidence of malformations with an ultrasound and studies, etc. Now, I would prefer to stop the drug if the patient is stable and continue. It's the mother's decision about the treatment, the interruption of the pregnancy. But the issue is mostly assess the status of the baby at that point, because obviously they have been exposed through the most critical period, and it could be that you already know that they have a malformation. That is information the mother has to know so that they can make an informed decision.
And no breastfeeding on TKI?
No breastfeeding on TKI, that's correct.
Any suggestion about pediatric CML? Any drug of choice or anything?
No, but little by little we're learning that they all seem to work and seem to be safe. There's already a little bit of data with TFR, so it's the one thing that we see is that the children end up being shorter. That's the main difference in terms of adverse events, that the effect on their height. They're healthy children, but they're just shorter.
Imatinib produces growth retardation and all these things. Are there any preventive steps or any?
Preventive steps for what, I'm sorry?
Growth retardation, bone metabolism, all these things. Are they restricted to imatinib or they are with all the TKIs?
No, they are with all of them. And I don't know of any preventive measures, although, I haven't seen anything.
Right. Well, I think we are almost towards the end of 2 hours. Yes, Pankaj, you still have a question, yes.
So last question, sir. Sir, how will you manage a case of CML with CNS blastocysts?
We certainly need intrathecal chemotherapy. We know that Dasatinib crosses the blood-brain barrier, but it's not enough to be dead treatment for CNS disease. We need intrathecal chemotherapy. It helps if you have a TKI that goes to the brain. It may add to the benefit, but I wouldn't just do that. I would do intrathecal chemotherapy, possibly radiation, and then it is usually good to give them systemic chemotherapy with chemotherapy and all that. Even if you don't have systemic disease, eventually those patients can relapse systemically.
Right. Well, I have no words to thank you. This has been a great evening. We have learned something in 2 hours which we didn't learn in last 20 years. If other faculty members would like to respond and give some comments. I'm sure you all echo what I said.
Yes.
We all learned a lot.
Excellent. Wonderful session. Wonderful sessions. Absolutely wonderful.
Yes.
Thank you very much. It's my pleasure. I really enjoyed it, and I remember very fondly my trips to India. I've had a few, and
yes.
hopefully I'll be able to get back there and visit with all of you and have some wonderful Indian food.
Thank you, sir. So over to the organizers, Lupin, for the last word and vote of thanks.
Thank you so much, sir. Thank you so much for a very enlightening session. And on behalf of Lupin, I would like to extend a sincere gratitude to each one of you present here, Dr. M.P. Agarwal, sir, Dr. Cortes, and all our panel members. Thank you so much.
I have a good news to share. Over 600 participants have logged in.
Oh, wow.
So we haven't had this kind of response for any session. Forget CML, any session. Our average attendance is 400, 450. But today it's 600 plus. With,
well, thank you everybody.
Fantastic. 50 of them out of this country. Great. Thank you. So thank you, sir, and have a wonderful day. Thank you.
My pleasure. You too.
Thank you.
Good night.
Thank you.